Hi everybody, and thank you for joining our 5th installment of the CRISP Webinar Summer Series. My name is Michelle Rubin, and I'm your guide through the webinar series. This is an opportunity for you, our users, to learn about CRISP, how we can help you and your patients, and directly interact with CRISP staff. If you missed the first 4 webinars, go to YouTube and find our channel, CRISP Health. You can also find the recordings on the Events and Webinars page of our website, crisphealth.org. A few housekeeping items. Everyone is on mute. If you have any questions along the way, please enter them into the chat box. Our presenter will answer them at the end of the presentation and get to as many as possible. Feel free to type the questions in as they come to you. We might not get to all questions, so we'll consolidate your questions and answers and send them out to this group and post them on our website. This webinar is being recorded, so if you miss anything, don't fret. We will distribute the slides, recordings, and the Q&A and post them on our website, crisphealth.org. To find the recordings and slides, go to crisphealth.org and select Resources. Choose the option Events and Webinars and scroll down the page for the on-demand webinar playlist. And look out for a brief survey. Please fill it out so we can improve the series. The comments so far have been very helpful. Just advance the slide. Today's webinar will expand on last week's introduction to the unified landing page. You have all of this data, so how do you incorporate it into patient care workflows and leverage it for improved clinical decision making? Our presenter today is Dr. Samit Desai, Clinical Advisor at CRISP. Samit, take it away.
Thanks, Michelle, and thanks to the folks taking time out of their day. As Michelle said, CRISP has collected a lot of data over the years, much of which I hope many of you have had the opportunity to interact with and help inform your decision making. But over the last couple of years, we've begun to incorporate new types of data that we believe will really advance the management of population health and other use cases. And so we hope to talk through the state of the data that we collect and how you might find value by viewing that data through our new portal, as Michelle referenced. So we are going to talk through the clinical data through the lens of the ambulatory community. But for the most part, I think it's fair to say that this would be applicable to most users in acute care settings and post-acute care settings. So hopefully you find it valuable. So the way we're going to approach thinking through the value of clinical data is how it informs real-life clinical decision-making on the part of doctors and nurse practitioners and PAs, really any individual in the spectrum that must make important decisions for their patients. But then also specifically around how we can support medication reconciliation, which we know is a vital element to good care, and some of the tools and data that we have available that uniquely support that workflow. And then finally, as I alluded to, CRISP has collected and has stitched together many of the organizations in the community in support of better care coordination. And as our tool set advances and becomes more sophisticated, we really want to talk through how your organizations, based on feedback we've received in talking with folks, how you all could look to leverage it. And then in the second half of the webinar, we want to talk through some very basic workflows that your practice may employ to get the information into the hands of folks that can act upon it. And then finally, we'll end with some basic feedback and question and answer, as Michelle pointed out. So as we just mentioned, as one thinks about the value of clinical data, front and foremost is this idea that we can alter or improve the clinical decisions one makes. And on some level, that's a pretty basic fact, that more information can improve the decisions that doctors make every day, nurse practitioners, PAs. And so we often think about that as reducing unnecessary testing or potentially unnecessary testing. And that is a very key element of how the data that CRISP aggregates can provide value to your teams and the patients you serve. And that may take the form of not having to repeat certain advanced imaging studies like MRIs and CAT scans and ultrasounds. It may mean that you don't have to repeat certain tests or procedures. But we also know that the value of the data isn't just in reducing repeat studies. It helps one interpret new presentation of illness. And even if one were to order the studies again, and we'll talk through this later, comparing it to prior data helps inform future workup and gets patients down the right path of care, which at its essence is the fundamental mission of CRISP, that we enable quality care. And if we can reduce utilization, reduce duplicative testing, then that is certainly a benefit. Again, with respect to medication reconciliation, as I referenced, we're going to talk through how a particular type of document called the continuity of care document, which many of you may be familiar with, is a templated standard with common elements like problem lists and medications and allergies, how those types of documents can be mobilized nearer term than discharge summaries and other types of documents to support follow-up care. And then, as I referenced, our ability to support what we call an integrated care network moving forward. So as we step through the different types of information, there are three core pieces of information that I'll focus on. Of course, we collect a wider swath of documents or of data. Before I step through what we call transcribed documents and imaging results and lab results, it's important to note that one of the most important pieces of data that CRISP collects are encounter data. And while we're not here to talk about the encounter notification service, by virtue of that service, we now collect encounter data from every hospital, from 2/3 of the skilled nursing facilities, many of the home health agencies, and an increasing number of ambulatory providers. And how that, I think, can play well and be a guide to how one navigates CRISP services is that I sort of think of it as a table of contents. And anyone who may be seeing a patient for the first time will look through encounter history and look where they've been. And oftentimes in traditional EMRs, diagnosis data will exist for a particular hospital event. And that serves as the impetus to then dive deeper into a particular visit and read that visit's discharge summary or consult notes. And so historically, we've made the encounter data available through the query portal. And as for those of you that were able to attend the last webinar, Ryan pointed out with our new Snapshot app, we're now increasingly showing encounter data in sophisticated ways. And in the coming weeks to months, you'll notice that we will be including diagnosis data that hopefully helps you guide the swath of data that we're increasingly collecting in a more sophisticated fashion. So when we talk to primary care doctors and specialists who work out in the community and certainly home health agencies and really the gamut of providers in the ambulatory and post-acute space, I think we all understand that discharge summaries is the most important document that we make available. And as many of you know, we collect that from the vast majority of hospitals. And in the feedback and Q&A that we'd like to collect, if you note that there are instances where you're not seeing such documentation when expected, we certainly want to hear about those things. But we all know that discharge summaries are sort of a consolidated story that doctors and other providers make available after what could be a complex event in the hospital. But associated with that discharge summary, we increasingly collect a variety of documentation types, from H&Ps to consult notes and procedure notes. And what we've heard from the primary care community is that consultation notes, like from a cardiologist or a gastroenterologist or neurologist, can be really valuable when those patients follow up, or if they've gone a long period of time without having seen their primary care doctor. The richness of detail and the sort of assessment of specialists in for whatever clinical presentation, whether it's a headache for a neurologist or seizure activity, or if there's an assessment of gastrointestinal bleeds from a gastroenterologist for which an endoscopy was performed. We hear loud and clear that those are very vital, and we do make active attempts to reach back to health systems so that they incorporate such information. And then the final piece of type of document that I'd like to focus on are procedure notes. A good percentage of outpatient activity is referring for particular procedures to be performed. As I alluded to before, endoscopies and colonoscopies. On the cardiac realm, stress tests in particular. And so to the extent that we are now making these procedure notes increasingly available, we believe that from the ambulatory space that you'll find that of particular value as you make judgments about whether to refer patients at all. As we pass through to imaging results, I think we can all agree that knowing the prior imaging status of a patient, again, as I alluded to before, can help reduce the repetition of that event, of that study. And when you look at HIEs, when people study HIEs, this is one of the clear wins, is the ability to reduce repeat MRIs and CAT scans and ultrasounds. The other types of imaging results, depending on how you want to categorize them, as I alluded to before, are echocardiograms and stress tests. And when we are out there talking to you all and other folks in the community, we hear loud and clear that to the extent that we can capture and make available echocardiograms, that primary care doctors and other provider types would find great value in not having to repeat them or to better understand their patient's state of care as it relates to their heart. And then finally, lab results. At the moment, CRISP does not engage in results delivery. Most of your organizations have probably accounted for ways in which the tests that you order through your practice, the results of those can come back to you all. But showing the historical data, and I give examples of hemoglobin and hematocrit, which often are the type of data that primary care doctors and specialists need to track for anemia workup, for example, or when we track folks' kidney disease and whether it's progressing. We really have a trove of data within CRISP that dates back at least 18 months, and as time goes, we're going to look to expand that time frame so that when you're seeing a patient for the first time, or there's an extended gap, or a patient presents newly to you all, you can readily access that data to make the right decisions. As we know, knowing a prior hemoglobin or hematocrit can mean the difference of doing nothing versus an extensive evaluation for intestinal bleeds, or iron deficiency anemia, and a wide variety of illness that we would find cause to evaluate. So as we move on, I had alluded to medication reconciliation before. Many of you may not know this, but we do collect from a majority of hospitals clinical data that is fairly real time. That after a discharge, for example, discharge medication reconciliation is done by the service. And that data is automatically embedded into this continuity of care document and then pushed to us. The beauty of that workflow is that one of the most important pieces of information we know primary care doctors need post-discharge is an up-to-date medication reconciliation. What meds have changed? What are the new meds that have been added? What has been stopped? And while it's been a chronic but improving problem, discharge summaries are still too often delayed. And we know hospitals are improving the turnaround time with which they ask their doctors to complete these, but we do at CRISP rely on doctors to sign these summaries before we can make them available. So as the unified landing page becomes broadly disseminated to you all in the coming weeks, and the Snapshot app is available now to you as well, you'll see a little what we call a widget, but a little viewer of continuity of care documents that your teams will find value in accessing. Moving right along, I referenced in Maryland with the waiver in place, and really across the country, organizations are trying to get better at care coordination, truly coordinating care across a number of organizations. And by virtue of ENS, the encounter notification system that CRISP has made available for the past 5 years, we now have deep insights into who's following patients. And we often now find, so if I work in the ER at St. Agnes, multiple organizations following a patient at once, many of whom don't know that the other organization is following that patient. And so we've found that while physicians can access this, and there will be value in them seeing this data, embedded care managers and care coordinators, for example, with PCMH programs and others that are coming, will find that that data is of particular value as they seek to coordinate care. And so what does that mean? Health plans have signed up for patients, many of which have made care manager data available that can be an individual to perform outreach to. We've seen increasing number of care coordinating organizations, if you've heard of Healthcare Access Maryland or the Coordinating Center, that make care managers available to provide follow-up care and to link to resources that might be otherwise difficult to access yourself. And then we have begun to shine the light on the home health community, and understanding when patients are engaged or active with home health can go a long way to ensuring that you know a patient has the adequate resources at home, which can be in a fundamentally different conversation as we all look to ensure that patients are cared for well, especially in transitions out of the hospital. And then I mentioned here at the bottom, soon the program director. Many of you are hopefully familiar with the program directory. It is what it sounds like. It's a directory of programs that have been stood up across the region and detailed information about what they do, how you might access those resources. And so right now, that's typically made available in the context of many hospital EMRs. But in the coming months, you'll note that information become incorporated into our Snapshot app. And that will be a great complement to the care team information that I just referenced. Hopefully many of you have heard about the Care Alerts initiative that's Maryland-wide. It was an organic initiative started by many of the hospitals that where we created distilled information that was most relevant to a patient that could improve decision making, and that wasn't easily deciphered by reading tomes of discharge summaries and consult notes. And so the next phase of that is led by the Maryland Patient Safety Center, which we at CRISP support. And the effort is to improve the quality and consistency of those alerts. So hopefully, as you begin to use the tools and they're more present to you, you'll begin to see the Care Alert data and find value in them. And certainly we want to engage the ambulatory community in the creation of these alerts. You often know patients the best and know their social dynamic and family dynamic intimately, and we can hopefully provide a good avenue or vehicle to disseminate that information. You'll see an email at the bottom of the screen from Faye Nieves, who is leading the effort at the Maryland Patient Safety Center. Feel free to reach out to her if you have more questions about how you can contribute or, frankly, how you might want to see such data. And then the last piece that we wanted to focus on is we know that workflow is everything, especially in a really busy clinic. It's not easy to go onto a website every time. We at CRISP spend a lot of time thinking about how to incorporate this data in as seamless a fashion as possible. So this goes without saying, you all have sophisticated practices where everybody operates at the top of their license. But we want you to think of CRISP in that same fashion. And we'd encourage you, as many practices have, to leverage the team, whether that be a medical assistant or another office staff member. You can, as a physician, delegate access to those individuals, and they can gain access to the CRISP clinical data, and through the workflows that you all establish, look to incorporate it or bring it to light. And so there are two tranches, really. One is this notion of pre-visit planning. We see a lot of organizations in anticipation of events or scheduled appointments click onto CRISP, log on to CRISP, maybe print relevant documentation. Now with our Snapshot app, again, we have hopefully this table of contents that will guide your staff to then go into the traditional portal that you all are familiar with and find the right discharge summary or consult note that may be relevant, laboratory data that may be relevant. And it is all printable. And if an option to you all can be downloaded as a PDF and incorporated into your EMR, which we are seeing as well. So we'd stress that pre-visit planning can be a great way to incorporate the data in your day-to-day. And then, of course, there's the traditional means of accessing patient data that's prompted by the patient stating they were recently hospitalized, or if you have suspicion that more workup has occurred and you need to access CRISP to answer a certain question. We now have this unified landing page, which Ryan Bramble discussed in detail last week or the last session. And we hope that that one-time login and one-time patient search to then access all the apps provides as seamless an experience as we can. I would just note that in the hospital world, we have great success in single sign-on, and for certain EMRs in the ambulatory community, we are pushing forward with the single sign-on option. It won't be there for everyone, but could be there depending on your EMR. And then the other just sort of look forward that I'd like to talk about is there are finally meaningful national information sharing networks, and many of the ambulatory vendors have signed on to those networks. And so CRISP, I think within the year, will look to make the data that I've just referenced available within the context of your EMR, just as you might search another hospital or another organization for the data that they possess. So continue to look out for that. We're really excited about leveraging new efforts and new technologies to bring data to you. Really quickly, this is the snapshot view that I referenced. You can see the encounter data. This is obviously in a test environment where so we don't have real live data for you. But the encounters, the clinical documents, which are those CCDs with hopefully good medication lists for you. Care alerts, again, that distilled information. And and then the care team here that we talked about for care coordination. And then you can use that really readily in concert with what we now still call the query portal, which is the CRISP portal that I think many of you are familiar with, and that includes discharge summaries and other documentation. So as we begin to wrap up, please take note of a link for providing us feedback. We monitor it closely, and we really do take your information to heart. We understand that only by listening to you can we advance the tool set and the data that we know is valuable. So please access it. There's a link right within the unified landing page, and it's secure. So you can include patient information if you want to report bugs or activity that may be off for a given patient. Great. So please feel free to enter questions in the chat box, and maybe we can take a few here. So the first question is, are the care alerts customized between the different healthcare institutions, or are they standardized across all of them? Is this centrally managed as a collaborative effort across healthcare providers? So I'll take the second question first. The Maryland Patient Safety Center, in concert with CRISP, does serve as sort of a central management of the effort, but it is, yes, absolutely a collaborative effort. As I mentioned, it began organically with organizations themselves, and then we worked closely with the Maryland Hospital Association, what we call the Care Alert Sprint, in early 2017. But the intention here is that we can push across silos and make valuable information available across organizations. To this question, are the care alerts customized between the different healthcare institutions or standardized? We have a white paper that if you are interested, we can make available that acts as a guide. We don't want to be too prescriptive with the type of information that's included, but just generally provide some guidance. So it isn't overly standardized, and we did work closely with leadership from all organizations to determine whether some basic standard would be valuable, and ultimately landed on deferring to the organizations and their expertise to include the right type of information. But I will say that, like any effort, some of the care alerts are wonderful and actionable, and others aren't so much. And this Maryland Patient Safety effort is to begin to cull less valuable care alerts and ensure that when we talk to organizations that they include the type of information we know can be valuable. Are there any options for more custom alerting based on around a hospital's specific needs? So the Encounter Notification System, which is our alerting platform, has a fair bit of configuration built in, whether you want to see certain data types or certain event types or event types from certain organizations. That's something we can do for you now. And I'd encourage you to reach out with the specific needs. We are quite flexible with how we can deliver data to you all. If you have a follow-up there around a specific need, I'm happy to address it further. A mobile app for PDMP would be very helpful. Any plans for that? So I do believe that, and there are better experts here about this subject than I, but CRISP, in concert with MedCai and a vendor known as Doctor First, has made PDMP data available at the time of e-prescribing through that app. If you can provide your contact information, we can provide you information with that initiative. Beyond that, we don't have a CRISP mobile app currently in the works, but we do hear from time to time that given the mobility of providers and care managers and care coordinators, that we might find great use in standing up a lightweight app that folks can access data through. Which EMRs have the single sign-on option? So as it stands right now, the big three hospital EMRs, Meditech, Cerner, and Epic, both have what we call in-context delivery of data, when we make available data in the view of the clinicians. And then should you find cause to dive deeper, there are buttons that take you to the portal that we referenced earlier. In the ambulatory community, we've, I believe, started with Allscripts and are in either testing now or have gone live very recently, and are in conversations with ECW given the breadth of their base. But if there is another vendor that you think we would find great value in linking up early, please let us know. We do feel it is an important initiative. How is it possible to expand the data available to providers on the unified landing page? So if there's a follow-up there about the types of data that you might be interested in seeing, please let us know. Right now, as I referenced, we have a lot of those transcribed documents in the query portal, the imaging results, the lab results, the encounter data, the prescription drug monitoring data, the care team information. We're starting to incorporate, if those of you who are familiar with the query portal know, we used to show data from CaseMix, which is that claims-like data that every hospital has to submit to the Health Services Cost Review Commission. And we'll begin to incorporate that data into the snapshot within ULP in the coming months. And so the diagnoses from that claims data we find can be of value, medications administered, procedures performed. There is some limitation there around where it's done. It's usually in hospitals or what we know as regulated space. We've dabbled a little bit with the Baltimore City Health Department in helping them stand up their accountable health communities effort. And so we hope that there's a path to begin incorporating social determinative health-like data. That is still a little bit ways off. But if any other folks have questions about specific data that we should make available, or if you want to know whether we make it available, certainly that's a really important question for us. Great. Well, thank you all for joining. Next week on Tuesday, CRISP's Director of Maryland Programs, Craig Bem, will close out the webinar series by talking about the central role of patient relationships in all of CRISP's services. So thanks for joining. We hope you will join next week. Take care. Stop sharing.